Good. Um, Thanks everyone for your patience just while we have our usual sorting out technical hitches on a webinar. So thank you for joining us this evening. My name is Kate Thompson. I'm a physiotherapist by profession. I've been a member of the British Pain Society for a good few years, and I'm the chair of the Education Committee. So we are delighted to be hosting this webinar tonight and have lots of people who've given up their evening to join us. In a few minutes, Esther is just going to share some slides. I'm going to run through some housekeeping, and then I will hand over to our speakers for this evening. So a little bit about the British Pain Society, just if you don't know loads about who we are. We're the oldest and largest multidisciplinary pain organisation in the UK. We are multidisciplinary, very much a community of professionals. We champion person-centred approaches to pain care, advocate for better pain care with policymakers, and try and advance education, training, guidelines and resources, and promote research where we can to understand, improve understanding of treatment of pain. So just a reminder or advertisement, if you don't know, it is our 59th annual scientific meeting, which is in Harrogate this year, on the 21st to the 23rd of April. There's more details on the British Pain Society website if you want to take a look. So I'll just run through some housekeeping. We have 4 speakers this evening, all from different backgrounds and who have different experiences. And we hope that therefore brings some different perspectives around this topic, which is having conversations with people who are transitioning to non-cure seeking chronic pain support rather than medical cure seeking pain support. So we hope very much that it stimulates some ideas and some conversation. We have don't have all the answers at all, and would welcome very much any questions to go into the Q&A. So there was just a reminder on the screen there that we are recording, and the webinar will be recorded, and that will go onto our YouTube channel. And if you can therefore post any comments in the chat, that would be really helpful. So that's the last bit for me, actually. Apologies, there will be an evaluation form that you can collect. So if you're happy to sort of fill in the any bits of paperwork at the end that the Secretariat will send out to you, then that would be really helpful feedback for us. Thank you. So our first speaker is Lisa Blanchard, who is a member of the British Pain Society Expert Patient and Carer Committee and a lived experience practitioner. Lisa's employed by Frimley Health Foundation Trust Pain Management Service for the past 3 years and has lived with chronic pain for over 20 years. So Lisa, I'll hand over to you, and then I will introduce each speaker as we go through the evening.
Thank you, Kate. I'll just try and share my slides. Hopefully this will go well. Right, can we see it?
That's coming through, yeah.
Thank you.
That's great, thank you.
Okay, so good evening, everyone, and welcome to you all, and thank you for joining us this evening. So as Kate said, my name is Lisa, and I've lived with chronic pain for over 23 years. So I've worked as a lived experience practitioner in the NHS Pain Management Service for the past 3 years. So in this presentation, I'm going to share with you my own lived experience of being told we cannot cure your chronic pain, and I will share how I transitioned from a medical to a non-medical pain support and how this has shaped my pain journey and my role as a lived experience practitioner. So for about the first 10 years of my pain journey, I had certain expectations and beliefs about a medical service and doctors. And this was that someone somewhere could make my pain go away. And I spent years bouncing around the NHS, desperately looking for a cure. So pain impacted every part of my life, and I felt powerless, hopeless, and pain became my identity. So I'm going to read out some expectations and beliefs that I used to have. So I used to expect that medical doctors could make my pain go away, did medications to reduce my pain, and there must be an injection or a procedure that could help me. And I expected my pain to go away. And I thought, is this all in my head? So scans and tests didn't show any damage or any progression of my diagnosis. So why was my pain getting worse and spreading? So the day a pain consultant told me that there was nothing more they could do and I would just have to live with my chronic pain for the foreseeable future stays with me to this very day. At the time, it was truly devastating. There was nothing trauma informed about how I was told, and it seemed like there was no hope. However, this was 20 years ago, and fortunately, times have changed, and that's why we're all here this evening. And that experience has shaped my role as a lived experience practitioner within a pain management service and how I advocate for patients as part of my role. So, having being able to see both sides of the metaphorical curtain as a patient and as working with clinicians, I understand how challenging it is for a clinician to explain to a patient that there is no cure for their chronic pain, or what we offer as a pain service is not what they're expecting. So, working as part of a multidisciplinary pain service, I've observed many patients' first assessments alongside my colleague, one of which has joined us today. Hello, Sarah. And many patients' expectations are similar to those listed on the previous slides. So, often patients are unaware of who they'll be seeing in their first appointment and why. And this immediately sets them on the back foot when their expectations are to see a medic or a consultant, and they're met by different members of the team, such as a psychologist and a physio. So a lot of patients are still expecting our service to make their pain go away using medication, injections, other interventions, and maybe even surgery. So one particular patient's experience has stuck with me. So after a very long wait for their initial assessment, they were really surprised that their initial appointment was with a psychologist and a physiotherapist. And their reaction was along the lines of, if I'd known this appointment was going to be with a psychologist and a physiotherapist, I wouldn't have bothered answering the phone. So, supported self management was not what this patient was expecting from a medical service. So, also, feedback from clinicians was that they were spending a fair amount of time during these first appointments explaining pain science and introducing the idea of a sensitized nervous system, which explains our team's approach to pain management. Now, that's an awful lot of information for a patient to understand in a single appointment. So, how do we bridge the gap with these initial conversations? So, our service identified that patients' first appointments were confusing. They didn't know what they were expecting from our service, and how we manage chronic pain has changed. So, what helped me when I was introduced to the idea of supported self management? So, pain education helps. So, understanding pain. Once I understood what was going on in my body and that my nervous system was being overprotective or had become more protective, I then could understand why the medical approach hadn't worked. So, it's about meeting me at that point where I'm at. So, at points in my journey, I wasn't ready to hear about supported self management. I wasn't open to the idea of supported self-management. So it's about asking, is this the right time for your patient? So being treated as an individual and not just a diagnosis was a turning point for me. I wasn't just Lisa with this condition. I was Lisa as a whole person. What was important to me? How could the quality of my life be improved to do the things that I like doing? So it's also supported self-management. What does it look like? How does it work? It's important to be able to explain this to a patient in their first appointment and feeling believed and validated. Now, we often say to patients, we know your pain is real. I myself thought I was making my pain up for a while. It can't be this bad. I don't understand why. So tests and scans come back as normal. So this is important to tell patients that this isn't necessarily an indicator of how bad their pain is. Now, this is an awful lot to cover in one appointment. So in our service, what did we do about this? So we introduced an hour-long pain management information session, and this is the first contact that patients have with our service. So this covers our understanding of pain, what we do in our service and what we don't offer, what to expect at your first appointment, how long it will be, and what we'll ask. And we've had some positive feedback from patients in their initial consultations because they feel more prepared. And clinicians can focus more on the patient as an individual, and they're spending less time on pain education and describing what we do as a service. So, top tips and what would be helpful as a clinician for a patient is to use metaphors. So, explaining how the nervous system has changed over time and how it's become overprotective, and safe things can set it off. So, metaphors are a marvelous thing. So, we use a metaphor of a faulty car alarm that used to work fine, but it's progressively got more sensitive, and now it's set off by a gust of wind. Or more recently, we had a patient saying that they felt like a meerkat, that they're constantly looking out for threat and danger. Using patient friendly language, so avoid overcomplicated and medicalized language. For example, use overprotected instead of central sensitization. Um, and acknowledge a patient's journey, be compassionate and reassuring. Um, explore what they're already doing. They may already be doing some self-management. So signpost patients to reputable sources. There is a lot of information out there on the website, on the internet, and pain education resources are so important because in a 1 hour consultation, when you've got brain fog, chronic pain, your memory doesn't work so well, remembering what you're told in that consultation is going to be hard. And also test the temperature. We've started to introduce PSEQ questionnaires before the patient sees us. So you can see how pain impacts them even before they've entered the room. And you can adjust your consultation based on that. So I hope this has been helpful, and thank you very much for listening and for your time this evening.
Thank you, Lisa. That was great and just perfect timing as well. Thank you so much. So I'm going to hand over to Tim now. So Tim Atkinson has lived with chronic pain for 30 years and is therefore an expert on it, having experienced it for such a long time. And has been putting it to good use ever since. Tim has written a memoir, Where Does It Hurt? And is helping to create and deliver a range of pain self-management resources and training programs with some partner organisations like Flipping Pain, Live Well with Pain. Tim's also a trustee of the Charity Pain Concern and vice chair of the British Pain Society's Expert Patient and Carer Committee. So thank you very much for joining us, Tim. I will hand over to you.
Thank you very much indeed, Kate. I'm hoping that I can share my slides with you, and if that looks okay, uh, there we go. I'm going to talk about the specifically the language. Thank you, Lisa, for teeing this up so perfectly, because my experience has been slightly different in some ways, and slightly less formalized in that I haven't had a role within the medical community. All my work has been from the point of view of the patient. And so I'm talking specifically about my experience, and I'm talking explicitly about what I've learned from a very personal point of view. I seem to have a bit of a problem. Oh no, there we go. I seem to have been asked by the host to start my video, but it's interfering with my ability to move my slides. But I think that's moved to the quote by Joanna Burke.
Yeah, we can see that.
Which is that pain is not hard to talk about, but it's hard to listen to for others. Because that's certainly been my experience over the last 30 plus years. You know, we patients with chronic pain must be really irritating to the medical professionals amongst you, because we don't get better and we don't often die in a timely fashion. Instead, we return on the revolving door of your consulting rooms, the heart sinkers and the frequent flyers, and we're in and out without there being any particular sign of progress. But there's an etiquette to being sick, as Anatoly Broyard said in his memoir, Intoxicated by My Illness. And we, as chronic pain patients, don't seem to be able to play the same game that you and most of our fellow patients are used to playing. Fear prevents us from being entertaining patients, says Broyard, and we still want doctors to be priests. And boy, do you guys like being priests to our supplicant patients. I had a quick look through some of my notes in preparation for this talk, and just to confirm a hunch that I'd had for many years, which is that there's a real dichotomy between the formal medical language used to refer to patients like myself and the conditions like we have, and the experience, the lived experience that we bring, and which makes us the whole patients that you need to treat. And there are just a few examples which are fairly standard, and I'm sure none of this will be a surprise to anybody here. Just try to, a phrase that kind of implies that you're not trying hard enough, or you're not trying at all already. You've got to fight this as if, what we've got is a battle that we need courage and strength in order to engage. And then there are all the other kind of very ordinary phrases that come in the CC'd letters that I see when the consultant writes to my GP, or when I see some other kind of notes in my patient record. Patient denies fever, chills, well, I don't deny anything if I'm reporting a real life valid experience to you. Or patient claims, and I'm going to talk about these infernal numbers again in a moment, claims pain is 5 out of 10. Does that mean it's been doubted? Does that mean if what I say in a consultation is being recorded on my note and communicated with my GP as a claim, that I don't think it does. I'm not going to over-egg this, because I think it's just the standard practice. It's almost something that healthcare professionals do without thinking. But after all, a fish doesn't know that it swims in water. And all this is nothing if not negative and stigmatizing and a normal part of most medical conversations. And it affects us. It affects us as patients, and it affects your view as healthcare professionals, whether we realise it or not. Words matter. It's my stock in trade. I used to be a teacher, and I gave that up 20 odd years ago to become an author. So I'm quite keen on words and what is hidden between the lines. And as you can see from that rather obvious example, it's quite easy, especially when you're under time pressure, to get things wrong. And that's the problem. We can get things wrong as well. We can make the wrong inference from the kind of words that are chosen and communicated to us, whether it's in a face-to-face consultation or whether it's in a follow-up written letter. And it can inappropriately render us the object of a doctor's action, which confers passivity on the patient, while emphasising that it's your position of power as healthcare professional to do something to us which will hopefully make us better. I think changing the way we speak also changes the way we think. And I think words often mask our true feelings. And it's very important to get these kind of words right when you're having a consultation with somebody with any long-term health condition, be it asthma, diabetes, or chronic pain. You know, these aren't the conditions that go away. These aren't the conditions that you can just dismiss with a prescription or an injection. These are the things that will be the things that need long-term, lifelong management. So what do we need from people like you? If that's the bad, then what do I think, in my experience, would be the good? And I think the first thing is to have accurate information about what pain is and what we can expect. And I'm sorry to report, and I hope this is my very unusual experience, that an awful lot of the pain interventions that I've received have been misguided from the point of view of being more appropriate to somebody suffering from acute rather than chronic pain. I have had conversations with very time-served and experienced healthcare professionals in which I've had the feeling that I may have known slightly more about chronic pain than that. And I'm not just talking about it from my own personal experience, which is clearly something which is cannot be denied, but I'm talking about from an understanding perspective as well. The point of knowing, as Lisa was saying, that chronic pain needs long-term and long-term support, and it takes time to get your head around the fact that we're not in a restorative medical model, but we're looking at something which affects the whole person. Because it's that information that fits in with our own experience that gives us a chance to normalise what we feel and hopefully then accept and be able to move forward with the fact that the pain we feel has a wider impact on our lives as a whole. And I think all of it comes down, at the end of the day, to a sense of control. We've got to have agency in this process. That's the really important thing. There is nothing we can do as patients embarking on a self-management journey if we aren't given a sense of agency, and if we're not given some sense of being in control of the process, because that's integral to pain self-management. But it doesn't fit with the traditional model of patient healthcare professional relationships. It doesn't fit with many healthcare professionals' understanding of what the patient is there for. You know, we aren't supplicants at the feet of the priest. We aren't passive patients in receipt of the infinite wisdom of the healthcare professionals. We have to really be, and I know it's a cliche, but it's got to be stated, we have to be partners in order to develop that sense of control. That comes down to having the knowledge and skills and resources to self-manage. That comes down to having an understanding of the pain that we're in and how we can help with your support, how we can help ourselves move from the place we're in to a slightly better destination. And I think at the end of the day, going back to the language, it's ultimately what Lisa also shared about being believed and about having our pain accepted for what it is. I've had conversations which have been, very dismissive. You can't be in that much pain, or you can't be in any pain at all because, and then there's an explanation that's related to some inflammatory factor that happens to be in decline in my latest blood test. The same went in the past for conversations about being on pain-killing medication. I'm now told that I shouldn't be on opioids. But I was told by people like you for the last 20 plus years that was the thing that I had to take. That was the treatment that was open and most successful. Conversations where disbelief morphed into escalating doses of prescription pain meds now tends to morph into a dismissal of my reality as a pain patient. I think, it comes back to giving me the time to tell my story, because there's an epistemic injustice if you consider me to be an unreliable narrator of my own lived experience. And if you approach somebody with chronic pain from the point of view of looking for the treatment for the condition, you're missing, the rather large elephant in the room. Is there a treatment for nociplastic back pain? No. But is there a treatment for the person with nociplastic back pain? Without knowing the person, there can be no long-term pain self-management. Treat the person, not the pain descriptor. And that, I'm just going to finish up by saying, brings me to that old bugbear of mine about pain scores. I know why you use them. They're all subjective in spite of the attempts to make things objectively quantify something. And I know you use them to measure the efficacy of the interventions, and it's about the only thing that you can do. But we're talking about pain, if we're talking about chronic pain at all, as a multifaceted personal experience. And that cannot be reduced to a single, simple physical sensation that you mark on a scale of 1 to 10. It is what it is. And unless you accept it as such, I don't think we can ever make any progress. Thank you.
Thank you, Tim, for speaking so honestly from your own experiences and perspective. I've got several questions that I wrote down, and I'm sure there will be others, which we will save until we've had listened to our next two speakers. So we promised to bring some different perspectives. So we are now going to swiftly move over to Dr. Mahindra Chincholkar, who is a consultant in pain medicine and anaesthesia and clinical director of the Manchester and Salford Pain Centre. Dr. Chincholkar is a council member for the British Pain Society and an associate editor of the British Journal of Anaesthesia Education, and his clinical interests are neuromodulation for chronic pain, neuropathic pain, and opioid reduction strategies. Thank you very much. I'll hand over to you.
Thank you, Kate, for the introduction. Sorry, can you see my presentation?
Yeah, we can see and hear. That looks perfect.
All right, okay. So I So I'm going to do a quick run through a point of first contact consultation. So obviously we know that's quite crucial to get it right, because if you get it wrong, you're going to get stuck in this cycle of prescribing medications and treatments that don't really work, and they cause distress to both yourself and the patients. The problem that we have is our consultation time is quite limited. So you might get, say, 10 minutes in a GP practice, maybe a bit longer in a secondary care setting. So the key is that we need to make use of this limited time to produce the greatest impact. And how do you do that? I think we can do that by focusing all our efforts on targeting the most influential psychological factors that influence outcome. And these are beliefs about the nature of the pain, specific fears about hurting, harming, or further injury, and beliefs or expectations about coping with the pain itself. So I thought it would be helpful to use an example to illustrate how this might work in practice. Just to clarify, this is not a recipe. This is just a framework to help you guide your consultation. And the QR code that you see on the right-hand side, this is a link to the pain management resources that the Salford Pain Management team helped develop. And this is hosted on the Greater Manchester Commissioning website. So you'll see lots of other case examples and resources that you can look at. So a fairly straightforward, typical history. So Louise is a 48-year-old female, long-standing back pain, has had back pain for many years, has recurrent flare-ups, some radiation of the pain in the thighs, doesn't extend to the knee, no bladder bowel dysfunction. Her function is quite limited. She's been started on opioids and the dose has escalated. So she's currently on a fairly high dose of opioids, Zomorph 40 milligram twice daily, and Oromorph. And despite all of this, most surprisingly, the pain is not controlled. And she's becoming increasingly more restricted. And this is affecting her mood. Has been now started on antidepressants, but that's not really working. Has had multiple investigations in the past, which typically show degenerative changes, but no real nerve compression. Again, this is a fairly typical patient that you would see in the pain clinic. Now, the standard consultation model that we are all taught, especially in medical school, is when you see a patient, you take history, you ask a few questions, and you then use that information to make a diagnosis. Possibly maybe order some more investigations to confirm your diagnosis and provide a treatment. And this idea of how a consultation should run is so embedded in clinical practice that when patients turn up, this is what they expect. They expect there to be a clear diagnosis, a simple answer, and a concrete medical intervention. But we have a problem, and the problem is that there often isn't a clear diagnosis. And although chronic pain is a diagnosis in its own right, especially in chronic primary pain conditions such as non-specific back pain or fibromyalgia, there isn't a clear anatomical focus. But often patients are still looking for a defined cause. So how do we proceed? How do we move the focus away from diagnosis, interventions, and treatments? So this is a 7-step model that we developed. This is based on the work of David Moyen. He's an Australian physiotherapist. Again, this is just a framework. This is not a recipe. So the first step is to ensure that it is safe to move. And in this case, what we're looking for is red flags. And if there aren't any red flags, we need to identify what unhelpful beliefs the patient has about the pain. What do they think the pain is due to? Are they worried about what it all means? So in this case, for example, the patient has attributed all of her pain to her work as a cleaner. And this message, unfortunately, has been reinforced by messages from another clinician who said that she's got the back of an 80-year-old. Now, all of these unhelpful messages, they actually fit in with this patient's understanding of pain. So this patient might believe that being less active is actually helpful because it's going to prevent further damage. So what should be the main goal of our consultation? The main goal should be to introduce this concept of safe pain, which means that pain can exist even without any ongoing damage. And although activity can increase the pain, can make it worse, it doesn't mean that they're harming themselves. That chronic pain can exist even in the absence of ongoing injury. Now, bear in mind that this might be completely contrary to patient experience, and if it's not handled sensitively, then this can be problematic. So effectively, what we are trying to do is we are trying to reframe the understanding of pain and help patients distinguish between what we call as protective pain or necessary pain. And how does it differ from persistent pain, which is overprotective and is not an indicator of ongoing damage? How do you introduce this concept? Again, there are different schools of thoughts, and I think Lisa alluded to this. One school of thought is you need to go into an in-depth neuroscience education. Unfortunately, there isn't enough time to do this, and I don't think this is really necessary. Again, Lisa alluded to the use of metaphors, and I find metaphors quite helpful. The metaphors that I tend to use in my clinical practice, and I'm sure many of you are aware of it, is that of a faulty fire alarm system. So essentially, a fire alarm should only come on when there is a fire, but sometimes it can become faulty and send messages on its own. Similarly, in chronic pain, what tends to happen is there often isn't any tissue injury, but they experience pain even when there isn't a tissue damage. And this is because of an oversensitive nervous system. Now, it is not uncommon for patients to then think that the clinicians do not believe them, that it's all in the head. So I think it is really important to state this very explicitly, that your pain is real and that it is not in your head, that we believe you. You're not making it up. It is simply how your nervous system is working. Now, once you've communicated, it's safe to move. It's essential to explain what the goal of movement is. Because patients will often say they've tried this, they've tried exercise, they've tried physiotherapy. It did not work. It's just made the pain worse. So you need to be clear that moving will not take the pain away, but it can help you do more despite your pain. And if you don't move, these muscles will stiffen up, which means you'll end up doing less and less. So essentially, pain management is not about reducing pain. It's about improving function. And it's also important to tell patients that when they first start moving, they may notice that their body is a little bit more stiff or they experience more pain. But by slowly and gently increasing the activity levels, these muscles will become more flexible and they will ultimately be able to do more. Now, medications is an entirely, it could be an entirely new talk, but I think it's also important to introduce this idea that medications actually don't help in chronic pain. And even when they do work, they only reduce pain by 30% at best. So this patient is on high-dose opiates. And again, it's not unusual for patients to say that when they were first started on opioids, it worked, but now it's not working anymore. And the natural assumption is that, okay, if it stopped working, then we need to increase the dose. But clearly that is not appropriate because patients will simply become tolerant to it. And this is how patients end up with escalating levels of opioids. So how can we move the conversation away from escalating opioids? Patients might say that, okay, I'm sure the painkillers work because if I miss a dose, the pain was really, really bad. Of course, you can talk about adverse effects in terms of immune function, endocrine function, sedation, and so on. But that often does not work. Simply saying something is bad for you doesn't stop somebody from taking it. I think we really need to put the opioids into context, and we need to talk about tolerance. And it is important to explain how opioids can be used more effectively. And this might seem counterintuitive, but by actually reducing your opioids, you're making your body more sensitive, which means when you actually need the painkiller, there is something for you to take. When we talk about opioid reduction, there isn't an absolute rule. You could tackle the long-acting medication first or the immediate release. It doesn't really matter. As long as the trajectory is downwards, any approach is appropriate. Step 5 is how do you ensure that the patient moves? Again, you might Some patients might benefit from referral to physiotherapy. Some patients are happy with managing their own pain. But again, it's crucial to put physiotherapy in context. Physiotherapy is not going to take the pain away. Again, it's more about getting patients more functional. Although some patients might gain some pain relief from reduced muscle spasm. Encourage other pain management strategies. And if patients are really, really struggling, if they're struggling to reduce the opioids, and if you feel that they would benefit from a more specialist input, then you could refer patients to the pain clinic. So this is a quick whistle-stop tour. Obviously, there's lots of things to cover which haven't been able to, but and there are lots of themes which overlap between different talks. But it is important to acknowledge that any realistic change is going to take time. We can't expect to cover all of this in one appointment, which means you might have to bring the patient back. But you should really take this opportunity in the point of first contact clinic to introduce this idea of self-management. Thank you.
Thank you very much, Mahindra. That was again right on time. So thank you very much. Great and great, some good stuff there. We will move on to our final speaker now. So I will introduce Jen Ford. So Jen is a physiotherapist, a consultant physiotherapist and co-lead of the Bath Centre for Pain Services, which is a national specialist rehab centre for people of all ages with complex pain-associated disability. She's also an executive committee member of the Physiotherapy Pain Association and the British Pain Society Pain Management SIG. Thank you very much, Jen. Your slides are sharing perfectly there. I will hand over to you.
Thank you, Kate. Right, so generally when people are referred to Bath, they have got to the point where there's kind of no further investigations or treatment being considered. So the first time we meet them is when we are expecting to start the conversations about moving to a non-curative approach. So the aims of the first meeting for us are around doing a full biopsychosocial assessment, starting to build a relationship with the patient and their families, and to deliver some pain science education. And just as Mahindra said, patients are often have a really good understanding of the medical model. They're expecting to see a medical professional to get a diagnosis, have some treatment, and for their symptoms to reduce or be resolved. So we're very much talking about how rehab is about gradually getting the important things back in life in the presence of ongoing pain. And we talk about how it's not about waiting to feel better or for treatment to take the pain away. And that we're going to keep function and getting back to doing what matters as the metric for success. If your patients are still using pain as a guide to whether treatment is working, then we're always going to fail. I think it's really important to understand our patient's perspective. And I think moving from a medical curative approach can actually be deeply challenging for our patients and very emotional and can often be an almost transformative experience. We know that people describe feeling really scared, feeling really frustrated. Maybe it's been years of trying to find out what's wrong and ways to fix it. And they can experience grief for how they used to be or kind of future opportunities. And it can sometimes feel like they're giving up or there's some resistance to giving up on a cure. And if we accept a non-medical approach, they might worry that that means that it's less serious or that they're not going to get help. And I think particularly, you know, for young patients, considering what that might be like for their families as well. We know that the NICE guidelines for chronic pain really emphasize the importance of a collaborative relationship with our patients. And I think really in that first appointment, we really need to get to know the whole person. This is, you know, the whole point of the biopsychosocial model, you know, really getting to know them, how pain is impacting on them. It's really important to validate patients' pain, but also the experiences that they've had. And just like Tim said, patients shouldn't feel like we're prescribing to them. We want them to be an active partner in their care. And they need to have faith in their team. We need to build trust with our patients. So everyone's sort of mentioned pain education already, but I think it's really important to not assume that this has already been covered in other appointments. Or if it has, can we use this appointment to check out a patient's understanding of their pain? And I really think that first appointment, we should be asking patients what they understand about what's going on for them. And there are really important messages that we want to make sure we get across, that their pain is real, but that it's not harmful. And as Lisa said earlier, using metaphors can be really good, diagrams, using other resources like, videos on YouTube, but just, it's making it individualized and asking the patient what works best for them. As part of your assessment, I think it's really important that we are assessing a patient's readiness for change. Working out what stage your patient at will guide kind of what support that you need to give them. So if you want to find out a bit more about the readiness for change model, I've put a little, not a link, but I've put a bit about some of the articles that are available around this. But some patients might be in this pre-contemplation phase, which basically means that there's kind of no intention of behavioural change, or they haven't really considered or been aware that there's a need for them to change anything. Or they may be moving into contemplation, where they're thinking about the possibility of change at some point. The preparation phase means that people are actively considering making changes. There's an openness to new ideas. And then action is when a patient is modifying their environment or their experiences or their behaviors. And then there's the maintenance phase, where you're continuing to work on those changes. There's a number of strategies that I think are really useful for starting to talk about change. So motivational interviewing is about eliciting and reflecting change talk. It's also about minimizing sustained talk, so reasons not to change, and using strategies to evoke conversations about change. And again, there's a couple of useful studies there if people are interested. So one study is kind of looking at using motivational interviewing in like a pre-program appointment, and it showed a real increase in adherence to pain management programs. And the other one is a literature review of randomized controlled studies using motivational interviewing with chronic pain patients. In Bath, we use an acceptance and commitment therapy model, and creative hopelessness is a kind of core technique that really kind of involves recognizing the futility of trying to control or get rid of negative thoughts and feelings. The kind of creative aspect of it is about encouraging people to find new creative ways to manage these inner struggles. And then workability is about asking your patient to look at kind of things they've already tried or things that they're kind of doing, and looking at actually what is the impact of that in both the short term and the long term. Now, I had a long chat with a patient in preparation for doing this talk, and unfortunately, I don't think the video will play. I will just try it quickly and see if it works. Can anyone hear that?
The video is playing, but the audio isn't coming through.
Okay. So Terry is a patient who was referred to our service 5 years ago. And at that time, it was decided that he wasn't ready for rehab. And he was sent home again. And he was kindly sharing some of his experiences of what that was like and what had changed when he came back to Bath 6 months ago. It was a very long video, which we managed to cut down, and I wish I could have played it all for you. But I think what Terry really shared is that even though he really wanted support. Actually, he wasn't ready to make changes the first time. And the difference was that 6 months later, he knew that he really wanted it, and he knew that he had to make changes. So, oh, it's trying to play again. Sorry. I'm trying to move on to the next screen. I might have to move the video to the end to do that. No. There we go. So just in summary, I think it's really important to validate our patients' experiences, provide education and skills, and build relationships with our patients and their families. But I guess what I've learned from kind of talking to Terry and from previous experience is that sometimes it's not the right time. And our job is to really kind of sow those seeds so that we're kind of leaving the door open for when a patient is ready. And when it is the right time, they're going to get so much more out of it. Thank you very much.
Thank you very much, and thank you to all of our speakers for taking the time to do that this evening. So we've got time for questions now. I'm wondering whether we can pop videos on for questions, and that might be useful. So I think there are some questions in the chat. Margaret, have you been monitoring the Q&A, not the chat? Is there something in there? I think there's a few questions, haven't there, that's come in?
Yes, there are a few questions. If you can hear me okay. The first one is Shoma, who's asking about patient journey, and some patients are not ready to take their patient journey. I don't know if Manindra wants to answer that. This is about thinking about how you might engage with people to get them to the point of readiness to think about the information science about pain.
Follows on from what Jen was just talking about, I think, as well, doesn't it?
Yeah, and there's also Sarah's question, who's recently trained in pain reprocessing therapy, and what is your experience of pain reprocessing therapy and changing patients' beliefs around pain? I don't know if Mahindra wants to come in there.
Yeah. Sorry. So the question was if patients have been told about explain the pain neuroscience, and if they're still not ready to engage, how do you proceed? Is that correct?
Yeah.
Yeah. So I guess all you can do is explain what chronic pain is, and if the patient is not ready yet to acknowledge that, and if it's still looking for solutions, it's still looking for the treatments, for the interventions, I guess they are not ready for change yet. And sometimes it takes time for the message to get through. And often I have organized investigations such as MRI scans simply for reassurance. As a patient, if they believe that there is something wrong in their back, until you can assure them that there isn't anything sinister, you're never going to get them moving forwards. So I guess it's a very fluid situation, and you have to be pragmatic on patients.
Should we come to you? You've popped your hand up.
Yeah, in response to that, although I think Mahindra might have covered some of it, I'd just say two things. One is, I really, in spite of what I've said and what I absolutely passionately believe about patient agency and our regaining of control over our conditions, there is an element in which we, as slightly ignorant partners, have to be sold this as a viable alternative to the years and years of prescription medication that we've been taking. And there is occasionally a feeling that I get both personally and in talking to other patients in a similar position, where if we're not at the stage of being ready to receive that message, we're being blamed. Almost like, a car salesman wouldn't blame you for not buying a car that he was trying to sell you. It's your job to sell it to us. And neither would he, to go back to the opioid scares and deprescriptions, neither would he dream of taking away the car you're already driving in order to get around. So I think there's a slight bit of nuance here that perhaps is important to consider. Patients can be encouraged, to be ready, more ready than maybe they might otherwise appear to be. And you mentioned, Mahindra, in your talk about the importance of education, but about the fact that the time factor was a massive disincentive to doing that. I think that time is huge, a huge and very beneficial investment, and should be made at the earliest possible opportunity. Personally speaking, it's been 10 years, 10, 20 years before I've actually been given any reasonable interventions in terms of pain science and self-management. That should have happened almost within 6 months of my initial consultation with a doctor. And if it had, I think I would have been in a lot better position now.
The time factor is really important, because the easiest thing to do is to, when someone comes in with a complex problem, is to offer a simple solution. And the simple solution is to provide drugs. It's far more difficult to spend time explaining pain neuroscience in 10 minutes. Then you've got the next patient waiting at the door.
I wonder whether it's I know, and I don't want to appear unsympathetic, but I wonder whether it is something that, as you realise in that first consultation that the time isn't available, whether you just have an open-ended conversation, which you then deliberately know you're going to schedule a follow-up to, which is going to hopefully develop that deeper understanding.
Absolutely, yes. I mean, one of the things that we have started doing in our pain service is, even before the patient comes in, when they get the appointment letter, there is essentially an introductory piece about what the pain service is about, and what self-management is about. We put different resources on the appointment letter. Now, whether patients read that or not, I'm not sure, but at least we have provided the information. So it shouldn't come as a big surprise when they come to the pain service.
I think there's lots of different ways of doing it. I think I know of services where they have, just pain education sessions that they can book patients into. Certainly in our service, we allow a 2-hour assessment appointment, because this is the first treatment, and it is, I would say, arguably one of the most important times. And so we really kind of prioritize that. But I know that's not always the case, and not always there's not always the possibility of doing that. But I do think, particularly with, these can be very complex patients. We know there's a high proportion of people with who are neurodivergent, who have chronic pain. And I think it's really important to remember that not just one way of doing it is going to work for everyone. Giving them just the same resources in the same way might kind of connect with some, but certainly not all. And I think we need to remember, metaphors don't work for everybody. Some people like video, some don't. And I think that's one of the reasons I think it's so important to get to know your patient and not just kind of think that one way is going to work for everyone. But I think it's so important, and I think we need to make sure that it's prioritized.
Okay, we've got a few more questions coming in. A couple have been put in the chat, but I think that one or two have been transposed over. So Shoma asks again a question for Mahindra, but please do everybody else come in if they got an answer to this. Mahindra, I've been lucky enough to liaise with some brilliant pharmacists who have contributed positively to opioid reduction plans because they know a lot about opioid formulations. Do you have experience of working more closely with patients' local pharmacists as well as their GPs when supporting reduction plans? Over to you.
So I don't have direct experience. I mean, obviously, I think we are a little bit isolated sitting in secondary care. Although we have had some pharmacists spend some time with our pain team, mainly to look at developing skills in assessing patients with chronic pain. How do you actually introduce this idea of tolerance, and how do you actually convince patients to reduce the opiates? We would like work more closely with the local teams. And I think there is ongoing work in Greater Manchester, mainly pharmacy led. And although the aim is about reducing opioids, I think you cannot look at opioid reduction in isolation. It has to be linked in with an holistic view of what chronic pain is. Simply identifying patients who are on high dose opioids and then cutting them down without an explanation as to why they need to be reduced, what else can be put in place, is unhelpful. And unfortunately, we are seeing a bit of this practice in primary care. So essentially, yes, we would like to have more links with primary care. We have some links at the moment, and we're hoping to expand on this.
Okay. Great. Louisa then asks, how do you explain to a patient that they're not ready for rehabilitation? Perhaps this is one for Jennifer, I don't know.
Hi. I mean, it's really hard, isn't it? People are, wanting help, wanting support. It's just working out whether that's kind of they're still wanting to find out what's wrong, or they're still trying to hope that there's something that's going to fix it or reduce it. I think sometimes, you kind of want to go for the easy option and say, yeah, no, we'll bring you in. And short term, they feel great because they're coming in for some rehab. You feel great because they've gone away happy, but you have to kind of look at the long-term consequences of it. And actually, you've got other patients on a really long waiting list who might get a lot more out of it and be seen sooner. That patient is not going to get as much out of it as they want to. And actually, they may have an awful experience of failing in their pain rehab because they weren't ready, because it wasn't the right time. So I do think it's hard, and I think you have to decide to be brave and to be honest. And that might not feel comfortable. They may go away disappointed, upset, angry. But in the long term, if you can build a relationship, if you can sow the seeds, then they can come back. And I think Terry was, a perfect example of actually, despite leaving very angry and very upset, he came back here and felt that he could come back, even though we'd had to send him away in the past.
Thanks, Jen. Greg asks, can I ask about the effect of living with long-term pain, specifically self-worth and self-punishment, and any experience with EMDR or CBT to work on coping mechanisms? I think that's quite a big question. I don't know who wants to come in and respond to that one.
Just before we go to that one, Margaret, I think Lisa was maybe going to come in on the last question, were you?
Okay,
Put your hand up. If I've got that wrong, don't worry. But were you just going to come in there on the last question?
Yeah, I was. As a co-facilitator of pain management courses, when we've got someone who isn't ready for change, the impact that they can have on other participants, on their peers, is quite significant. So, and telling someone they're not ready for rehab, they might not feel like they're ready for rehab. It's not like the be all, and it's a two-way street. But and also people that don't feel they're ready for change can be brought along by their peers as well. So the power of peer support is really powerful. Thanks, Kate.
Thank you. We needed time to think about the other question anyway. It was a long one, so.
No, it was. It's quite a big question. I don't know if it's about CBT and I don't know do you want me to repeat the question?
Sure.
Yes, please.
Okay. So can I ask about the effects of living with long-term pain, specifically self-worth and self-punishment? Any experience with EMDR or CBT to work on coping mechanisms?
Yeah, I mean, we know that long-term pain can have significant impacts on people in terms of mood, in terms of feelings of self-worth. But again, it affects every person differently. I think it is important to assess that and work with that. As I said, in Bath, we use an acceptance and commitment therapy approach, which is slightly different to CBT. It's kind of a third wave CBT. But there are lots of kind of different techniques and approaches. I think I'm not a psychologist, but EMDR is often used with trauma patients. And if we had someone where we felt specifically their trauma was affecting their ability to engage with pain rehab, then we may decide that actually we need to refer them for kind of treatment for that before coming back to us. So I hope that's sort of answered the question.
Yeah.
Is there anything else that person wanted to know?
I can't see anything else in the chat or the Q&A, but while you think about that one, perhaps another one for Lisa, because I think it probably relates to her experience. It's from Shoma again. She asks about, do you think as clinicians can learn from their own lived experience of living with chronic pain and working in chronic pain settings? And do you think there might be something we can learn from reflecting on the clinician chronic pain lived experience that may impact hopefully positively on how we work with patients?
I'm happy to take that one. So I don't actually class myself as a proper clinician. I'm the lived experience practitioner. So I do work with other clinicians that have chronic pain. Some are willing to disclose this to patients and others aren't. And I don't think that impacts how they work with patients. My role specifically I'd like to think, and the feedback is that it has a massive positive impact on people that come through our service. People have said that I'm an inspiration and I give hope that things can change, and I am very honest about my journey and how much hard work and determination it is taken for me to self-manage. So other clinicians, whether they disclose they've got chronic pain or not, is up to them. How helpful that is for patients, I don't know, but it's feeling understood. Is somebody in the room gets it. Somebody in the room knows what I'm thinking and knows what my life is like. So it is incredibly powerful. And I know that my team are brilliant in taking my views into consideration. And I've been told that in meetings they go, "What would Lisa say?" So my team are really, really good at looking through the lens of lived experience as well. And I do keep them in check quite a lot.
Brilliant,
So I hope that's answered the question.
I think it links back also what Tim was saying, and clearly we've got people who are not the people we need to change on this call today. They believe and listen to the patients that they're engaging with. It's possibly other people out there that we need to work on. Thank you, Lisa. Heather Wallace has also come back and said about, again, I don't know who wants to answer this one. Acute pain also responds to self-management strategies. Is waiting until pain is chronic causing extra difficulties? Why wait? Well, I'll wait for Mahendra and anybody else to come in, but I think the point being that not all chronic pain is always preceded by an obvious acute pain event. Other things cannot sometimes lead to chronic pain that is idiosyncratic or hard to diagnose. I'll let Mahendra come in there.
I completely agree. We know there's a lot of literature out there that whether it's post-operative pain or whether it's acute back pain, we know that if we intervene early and if we encourage patients to self-manage, to get moving despite the pain, we know that it can alter the trajectory. So yeah, absolutely. So for example, we know that after knee replacement surgery, for example, the patients who tend to develop chronic knee pain are the ones who don't engage with rehabilitation. So yes, and there are lots of interventions such as knee surgery schools, which essentially work on the same principle: intervene early to prevent the pain from becoming chronic.
Yeah, brilliant.
Thank
Thank
you.
you.
I think that's the questions done, is it, Margaret? In the
No,
Q&A?
there's just
Oh,
one more
sorry, I've
from
missed one.
Nalima.
This is why you do the questions.
I beg your pardon. Yeah, Nalima has just asked about pain assessment scores. It's just disappeared off my screen, but it is in the chat, the webinar chat. I can't see it now.
Let me scroll.
It's about the reliance on scales and about the difference between of application.
Yeah, I've just spotted it. I'll read this one out. So, yeah, this question is: pain scales are to measure pain, but pain differs between patients. How should this be addressed? Tim's laughing because you mentioned the pain scale, Tim, I think, didn't you, in your presentation?
Yeah, I did. And I can't offer an alternative. All I can say is that there is some fabulous work being done. If you've not come across Balbir Singh and the dance company that he runs in Leeds, Balbir Singh MBE, as in the recent New Year's honours list, in interpreting pain scales in any number of different creative ways. It may be worth Googling him and having a look. I think it comes back to just the story of the patient, the patient narrative. It's not enough. It can be a start, and I get why you guys need numbers, because that's how you measure things, of course. But there's an awful lot more to it than that. And if you are going to engage with the problem of chronic pain, which is a lifetime condition, like asthma, like diabetes, you're not going to send a patient out of the door cured. You are going to have to keep intervening, on a regular basis. You are going to have to understand it on a deeper level, and that could come down to very personal narratives that are made valid by the patient's own experience, and that need understanding and interpreting in totally unique ways. I don't think that's very helpful from a scientific point of view, but I think it's the only alternative that there is to really engaging people and making sure those patients, like Jen was talking about, and like one of the questions said, are ready to ready with their acceptance to move on to the rehabilitation journey.
Thank you, Tim. Lisa and Jen have both got their hand up. Just a second, Balbir Singh's work he does around unmasking pain through creativity, which, is a really creative and innovative approach. Very different to the numerical number scale. Super, thank you, Tim. I don't know who, there's three people, so all three of you have got your hands up, and I'm sorry, I didn't see who went up first. So I'm going to go on order of my screen. Jen, you're on the left of my screen, so I'll come to you first, then Lisa, then Mahindra.
Thank you. I think I was just going to say, Tim said we need numbers. We don't use pain scales. I think that's an important part of our shift towards this non-curative approach. Actually, your pain is going to go up and down. It may go up more as we do more, but what we're interested in is what you're doing and the things that are important to you. So actually, we stop using the pain scales because actually that's not the measure of our success. So yeah, just wanted to add that.
Thank you, Lisa.
So yeah, I can understand why as a service you use a pain scale. People with chronic pain are really good at masking it. They're really good at hiding it. It's largely invisible. And I know when you walk into A&E and they've got those little faces of how much pain are you in? And I'm sitting there in agony in A&E, and I'm as calm as a cucumber because I've lived with chronic pain for 20 years. So it's not a reflection in that respect. And also, sorry, my brain's just stopped working, everyone. Here we go, brain fog. So it has a use, but in other ways it's just like, well, you're just asking me to say 1 to 10. That's not how it impacts me. It impacts every single part of my life.
Thank you, Lisa. Should we go to Mahindra?
Yeah.
So from a research perspective, it's been recognized for a fairly long time that pain is multidimensional. And I don't think any research paper which has been published, say in the last 5-10 years, uses pain scores alone. They look at all different measures, not just pain intensity, but they also look at the psychological impact. And more importantly, I think as Jennifer mentioned, we are looking more at the impact in terms of function rather than impact on pain scores. Because often when we find that even if a treatment is effective and then patients start to do more, that's actually going to increase pain levels, but the function is improved. So pain score by itself is not a valid measure. We are looking at outcomes in terms of improved function.
Thank you. I've lost the Q&A, so Margaret, do tell me if there's anything else. I actually was going to throw a question in of my own if we have time. Listening to you all speak tonight, I was wondering to what extent does the setting matter? You know, we're talking about having conversations where people are shifting in what they've probably had long held beliefs around for quite a long time, and are clinical settings a good place to do that? Do you feel you need to frame your pain in a medical way in a medical setting when you're speaking to a clinician? So just interested to know people's thoughts on, you know, what's our creative thinking around, you know, where should we have these conversations actually if we could? We might not be able to, but if we could, you know, where would we go and how long would we have and who would be there? It's a bit blue sky, isn't it, for the end of the webinar?
I love that blue sky thinking. Oh, ideally, I would have the whole team there, you know, physios, OTs, doctors, psychologists. I think that would be lovely. And I think, you know, it should be in a place where the patient feels comfortable. Now, for some of my patients, that would be their worst nightmare, having that many people in the room. So they may just want one person and their family supporting them. And I think it's less about what I want and much more about what the patient wants. So where would be the best place for them? Who would be the best people for them? And I think, you know, my kind of ideal might not be theirs, but I definitely agree with you that the whole point of this non-curative approach is to get out of the hospital setting. We feel really lucky here because we're in a purpose-built rehab centre, which doesn't feel like a ward or a hospital. It is on a hospital site, but we're as far away from it as we could possibly be. But I think, yeah, I mean, in an ideal world, it would be where the patient is most comfortable, whether that's in their home, in their community, but certainly as far away from a hospital setting as possible.
Was it Lisa's slide that said, meet me where I am? Was that one of the tiles on your slide, Lisa? Yeah, that's interesting.
There are a few more comments in the chat and people are clearly enjoying this and have got a lot out of it. Katrina says, in her clinic, they often see patients who've been referred too late along their journey with automatic negative thinking, depression, etc. Need to see people sooner, at least to explore if they're ready. We're being referred patients who are now bedbound, who don't leave their houses, not eating, no self-care. So the demographic is clearly changing, possibly with the aging population. A lot of thanks and comments from people in the chat, supportive ones. That's nothing more on the Q&A.
Thank you, Margaret. In that case, I will just take the opportunity to thank everyone. Thank you so much, speakers, for the time you've taken to prepare for this evening and for sharing your honest experiences and knowledge and insights on this topic. And of course, everyone who has joined the webinar this evening, thank you so much. Thank you, Esther and the Secretariat in the background for making everything happen, and Margaret for taking the chat. In which case, I will say good evening and thanks again.